Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent educational grant from AstraZeneca.
This program is presented by Medscape Education Global.
Hello, I'm Erik van Kutsen, Professor of Medicine at University Hospitals of Leuven in Belgium. And welcome to this program titled Advanced HER2-Positive Gastric and G-Junction Cancers, and expert insights on current and future strategies. In this activity, we will be discussing the current recommendations for testing in advanced HER2-positive gastric and G-junction cancers, how to manage patients with this biomarker, using case examples, and look to key ongoing trials. In this chapter, I'm very happy to be joined by my colleague Frédéric Pénaud-Lorca, Professor of Pathology, Head of the Department of Pathology and Tumor Biology, and CEO of the Jean Perrin Comprehensive Cancer Center in Clermont-Ferrand in France. Together we will discuss the current recommendations in testing for advanced HER2-positive gastric and G-junction adenocarcinomas. HER2 amplification and overexpression is established as a targetable biomarker in gastric cancer. It's present in around 20% of gastric adenocarcinoma cases. According to tumor location, about 30% of the tumors at the gastroesophageal junction or the cardia, and around 15% of the gastric adenocarcinomas in the rest of the stomach are HER2 positive. Other than HER2, Frédéric, which other biomarkers should be tested for in patients with advanced adenocarcinomas of the stomach and the G-junction? And how do we test for them?
Thank you, Eric. Well, obviously, HER2 is probably the oldest one and the one we are used to look at, but we also need to look at PD-L1. We also need to have data about the status of microsatellite instability. And we have also two emerging biomarkers, Claudin 18.2. We also have FGFR2. It's a little bit early, but probably also coming. And the technique that we can use for those markers are different techniques. For PD-L1, for MMR, we Claudin 18 and FGFR2 beta, we need immunohistochemistry. If we want to confirm an MSI status, we can use also molecular biology. And for HER2, in fact, and I will go deeper into that later, but we have immunohistochemistry as the first test, and then in doubtful cases, in the 2+ cases, we can use in situ hybridization. Of course, next generation sequencing or PCR can be used for MSI or for copy number variation for HER2. One thing that is extremely important right now is that most of the biomarkers that we need, and basically all of them right now, we start with immunohistochemistry. That means that we need to have at least 4 to 5 good tumor biopsy. That means for the endoscopist to take out 6 to 8. In France, we say 10 to have enough material to be able to run the test. We need to optimize the test. And that's why right now what is recommended in most countries to test them right away on the first the first specimen that we have, because otherwise we can spoil tissue. So we are really in a tissue sparing strategy to test everything all together, to give a standardized pathology report with all the biomarkers. And of course, there are new biomarkers, so we have an important need for pathologist training, adherence to external quality assurance program to be sure that they are performing well the test.
So that's all very useful and very important messages for the clinician, Frederick. But could you give also a little bit more of details on how we test today for HER2 positivity using IHC and FISH?
So for HER2, the first test is immunohistochemistry. And then we can use a control by fluorescence in situ hybridization. And it is recommended at least for all patients with inoperable, locally advanced, recurrent, or metastatic gastric adenocarcinoma. And it has been recommended, as you can see, by many guidelines, ASCO, ESMO, College of American Pathologists, NCCN, and several local guidelines. So this is really something that is now reflex testing. So what are the rules for HER2 immunohistochemistry and what are our scoring criteria? First, we look whether we have a staining or not. If we have no staining, it's a 0. If we have a very faint staining that we have to go to very high magnification, it's a 1+. So those cases, they are considered as globally negative. Then we look at the intensity of the staining. If we have a very strong membrane staining that we can see at low magnification, it's a 3+. It will be considered as a 3+ if we have at least 10% positive cells or 5 clustered cells on a biopsy. So it's different between surgical specimen and biopsy. Then we have some cases with weak to moderate membrane staining. We have to go to 10 to 20x to look at them. Those cases, if we have more than 10% tumor cells on surgical specimen or 5 clustered cells on biopsy, we need to do in situ hybridization. And if we have a ratio HER2 sub-17 superior or equal to 2, those cases are considered as amplified, so they are considered as HER2 positive. So for anti-HER2 therapy today, the cases are either the 3+ or the 2+ amplified. So I have a question for you, Eric. At which point in the diagnosis treatment pathway do you send your patient for biomarker testing, and do you send them more than once? So do you ask for retesting sometime your patient?
Yeah, that's important questions. So we test all patients with gastric or G-junction adenocarcinomas at the first diagnosis of metastatic disease. There are no data that in the adjuvant or neoadjuvant treatment, the therapy is really, or the result is really predictive. So at the first diagnosis, optimally and in an ideal world, we would like to retest after a first-line treatment. Some studies have indeed shown that when a patient becomes progressive on trastuzumab plus chemotherapy or trastuzumab pembrolizumab plus chemotherapy, that some patients may lose HER2 expression. So before we start on a second-line treatment, in the optimal world, if there is tissue available, then we would eventually retest. So from the pathologist's point of view, what are the challenges with HER2 testing in gastric and G-junction adenocarcinomas, Frederick?
Well, our major issue is tissue heterogeneity. In fact, we have different level of heterogeneity concerning HER2. We have, first of all, a biological heterogeneity with a variation of HER2 status by tumor type. We have up to 35% of positivity in well-differentiated adenocarcinoma, and in diffuse cell adenocarcinoma, it's very low, 3-5%, maybe lower than that. So first of all, the tumor type, and so it's complicated when we have mixed tumor to have a representativity of the well-differentiated adenocarcinoma. You mentioned earlier the spatial heterogeneity. We have, first of all, an intratumoral heterogeneity in 30 to 50% of the cases. So that's why we need a lot of biopsy too, and also to perform the test on biopsy, and if we have after that a surgical specimen, to retest if it was negative on the biopsy. But as you mentioned earlier, depending on tumor location in the whether it's in the gastroesophageal junction where it's around 30% HER2 positivity, it's lower in gastric, and it's probably due to the higher level of intestinal metaplasia that we have in the gastrointestinal junction. We have also temporal heterogeneity. Usually when we compare primitive to metastasis, we have around a 90% agreement, but we can have a gain in HER2 positive cases in metastasis versus primitive. As you mentioned before, with patients receiving trastuzumab, neoadjuvant or first line, they can lose also the status. So it's very important, in my opinion, also to retest. And also, this is also a message for both pathologists and clinicians. If the patient is treated by neoadjuvant chemotherapy, some studies have shown that we can have a decrease in HER2 positive levels post-neoadjuvant chemotherapy, up to 10%, probably by killing the most aggressive subtypes. So also it's better to test before. The tumor heterogeneity is something that we see all the time in gastric cancer, and this is really highlighting the importance of many biopsies. This is also highlighting why the scoring is different in biopsy and surgical specimen. But altogether, I think that having a lot of biopsy, being able to retest on a surgical specimen or on other metastatic samples will help us to have a good view of the HER2 status. I have a last question for you, Eric. From the oncologist point of view, what are for you the major challenge with HER2 testing in gastric and gastroesophageal junction cancer?
Well, there are a couple. One is, as you mentioned already, that we need to be sure that we have enough tissue for the pathologist, and two, also the loss of HER2 positivity after first-line treatment. With the recent approval also of agents in second line, such as trastuzumab deruxtecan, we have to be sure that the tumor is still HER2 positive before we start with the second-line treatment in this setting. Frederick, thank you for this nice and interesting discussion, and thank you also for your attention. Please continue to listen to the next chapter titled First-Line Treatment of Advanced HER2-Positive Gastric and G-Junction Cancers. Hello, in this chapter I'm joined by my colleague Lizzie Smith, who is a consultant medical oncologist at Oxford University Hospitals in Oxford in the United Kingdom. And together we will discuss some of the new advances in the first-line treatment of advanced HER2-positive gastric or G-junction adenocarcinomas. And for that, we will start with a case example. It's a real case of a patient that we had in Leuven, talking on a 49-year-old man who presented in April 29 with dysphagia for solids since a few weeks and 3 kilograms of weight loss. He didn't have any medical history. The diagnosis was made of a G-junction adenocarcinoma, stage 4. It was an intestinal type adenocarcinoma, moderately differentiated, HER2-positive, microsatellite stable, and with a PDL-CPS score of 11. So we staged him for stage 4 because there were large lymph nodes around the celiac trunk. There were many liver metastases in both liver lobes, and several of these metastases were very big, up to more than 5 centimeters. His organ function was normal. His CA was elevated, and he was in imperfect condition with an ECOG score of 0. We discussed a long time. The patient was a very bright man who was aware of the new treatment evolutions, because remember, we were in 2019, and he was treated outside of a study protocol, but had access to the initial data that were presented on capecitabine, oxaliplatin, trastuzumab plus pembrolizumab. So we started this treatment, and after 4 cycles, he had a spectacular response on as well as primary tumor, as on the liver metastasis, with a clear decrease in his CA without major adverse events. We continued treatment, and almost 1 year after treatment, we did an in-depth evaluation with a new endoscopy, which showed a complete disappearance of the primary tumor. Biopsies also were negative in some scar tissue at this place at the G-junction. And the MRI of the liver was done and a PET-CT and showed only several calcifications in the liver, in the left lobe, and a few in the small right lobe. And there was also a complete response of the lymph nodes. After in-depth discussion with the patient and within the MDT, we decided to do a laparoscopic surgical exploration. And during the operation, there was a suspicion of still remaining liver metastasis. A left hepatectomy was performed, and a microwave ablation of 2 of the metastases of the remaining nodules in the right lobe were done. However, histology of this afterwards did not show any remaining tumor. In the postoperative phase, we continued with capecitabine, trastuzumab, and pembrolizumab as a adjuvant treatment until December 2020, so for 6 months, and a complete response was seen at every evaluation. And then we continued for 6 extra months of trastuzumab, pembrolizumab until July 2021, at which moment we had a complete response in this patient. So Lizzie, if you would have seen this patient, or if you would see this patient, what would be your treatment recommendation in a patient like that in first line?
So right now, if I saw this patient in 2025, based on the Keynote 811 trial, this patient being double biomarker positive for HER2 and PD-L1, there would be a clear guideline endorsed recommendation for chemotherapy, trastuzumab, and pembrolizumab. Because this improves overall survival by 4 or 5 months on average in the median. But I think what's key is it's not just about the median. What we see is this really incredible response rate. So you have a path CR, but we know we see RECIST responses in 75% of patients, and it's about the longevity of benefit as well. So this patient was able to have an operation, but even for patients who can't have an operation, we're looking at improvements in long-term survival. So for me, because of the double biomarker positivity, that's key. If you don't have both biomarkers positive, so if you're HER2 positive and PD-L1 negative, the recommendation is still for chemotherapy and trastuzumab, no ICI. That's a very important factor to distinguish amongst these treatments.
Yeah, that's correct. This patient, as I mentioned, was a bit before we had the data. There were phase 2 data. He was a fighter. And that's also the reason why in our MDT we discussed so much and long, and there was a clear participation of the patient. He was involved in the discussions. It's a bit outside of the box, so that we went to surgery. But there are, of course, no guidelines in this situation to endorse that. But it shows the potential of new treatment options for patients.
I completely agree. You know, care of gastric cancer patients is multidisciplinary. We're in new territory now. When we see these long-term outcomes for patients, in particular with targeted therapy plus immune checkpoint inhibitors, it's very reasonable in cases of very good response that is sustained to bring that patient back to the MDT and ask the question again. It's certainly something that we're doing in Oxford as well, in particular for HER2 positive patients. So I think having such an effective therapy available really does open up new opportunities for these patients. But you're right, we don't have a lot of evidence, and we should recruit our patients to clinical trials asking those questions. Now I'll come to you and ask the question. We've already touched on guidelines, and there were no guidelines in 2019, but this treatment is now endorsed by the ESMO guidelines and other international guidelines like NCCN. In terms of shared decision making with your patient, what are the conversations you had?
We had a lot of in-depth discussions, and the patient was initially looking for a center where Keynote 811 was open, but then he didn't want to be randomized in a trial because he was so convinced. He looked into the data that came from the phase 2 data from Memorial Sloan Kettering. We were in the beginning resistant. I explained to him several times that this was not validated, that this was not proven, that this was early data, that there is always a risk of more toxicity, but he persisted. He was really a fighter. He was a 49-year-old man, professionally very active, in good condition, and he was clearly informed that we could not guarantee a shared decision, but he saw the numbers of the abstracts and the initial presentation in 2019. Today, we would treat him in this way, and he's now very proud. I saw him a couple of weeks ago. He's free of disease.
I think that's absolutely true. And it's all about informed consent, you know, whether it's for conventional therapy, whether it's about clinical trials. I think that shared decision making is also sometimes, as you did at that time, sharing the uncertainty. And that uncertainty, though, for this patient turned into a very positive outcome.
Let's look in some of the key trials, ongoing trials in this area in first-line treatment of HER2-positive gastric adenocarcinomas. The Destiny Gastric 03 trial is a trial with different cohorts. It started as a phase 1 and then later runs over in a phase 2 with different arms, trastuzumab deruxtecan plus fluoropyrimidine plus checkpoint inhibitor plus pembrolizumab. You can see different dose levels that were in this trial. The data were presented at ESMO and ASCO GI of the different cohorts. And what is clear coming from this Destiny Gastric 03, the part 2, is that the arm with trastuzumab deruxtecan plus fluoropyrimidine plus pembrolizumab was very active with response rates, small trial, but up to 73% in IHC3 plus patients and more than 80% in IHC2 plus FISH positive patients. So that's very high in this regard. There are, of course, some safety issues, some toxicity, but toxicity was generally quite okay, at least with the dose in this regimen, trastuzumab deruxtecan 5.4 milligrams per kilogram in combination with 5-FU or capecitabine and pembrolizumab. And that's the reason why this regimen is taking forward, as I will show you in just a moment. What is also ongoing is the Horizon GEA-01 study with zanidatamab. That study has finished recruitment. Zanidatamab is a bispecific antibody, HER2-directed antibody, and in this trial, the control arm is capecitabine or 5-FU plus a platinum plus trastuzumab, and that's compared to chemotherapy doublet plus zanidatamab or a chemotherapy doublet plus zanidatamab plus tislelizumab, based on the Keynote 811 study that we just commented on. We are looking eagerly forward to see some of the data. I introduced already the Destiny Gastric 05 study. That's now a randomized study that has just started. It's a very important study looking at control arm, trastuzumab plus chemo plus pembrolizumab in the HER2 PDL positive patients, and comparing that with trastuzumab deruxtecan plus fluoropyrimidine plus pembrolizumab. And there is an exploratory cohort also in patients with the HER2 positive but PDL negative tumor, where chemo plus trastuzumab is compared to trastuzumab deruxtecan plus difluoropyrimidine. That study is just starting, and we look into and try to improve progression-free survival, and as key secondary endpoint, the overall survival. And then finally, another important study that is now starting, in the starting phase, is the Artimide Gastric 01 study. This is a study where the role of an anti-TIGIT NPD antibody, bispecific antibody, is investigated in combination with the fluoropyrimidine plus trastuzumab deruxtecan versus trastuzumab chemotherapy and pembrolizumab. So with the goal also to explore the activity of trastuzumab deruxtecan in this setting, in combination with the bispecific antibody targeting PD and TIGIT. So this trial will look at whether this combination will improve the progression-free survival and the overall survival. Lizzie, thank you for this discussion, and thank you for your attention to all the listeners. Please continue on to listen to the next chapter entitled Second Line and Beyond Treatment of Advanced HER2 Positive Gastric and G-junction cancers.
Hello again. In this chapter, Eric and I are going to discuss second line and beyond treatment for advanced HER2-positive gastric and GEJ cancers. As in the previous chapter, let's start our discussion with a patient case example. So in this chapter, we're going to discuss Catherine, who is our patient. She is a 60-year-old female with a past medical history of hypertension and anxiety. She has presented with dysphagia and a 10-kilo weight loss. So she's had a CT and a PET, which sadly show metastatic disease. She has quite bad dysphagia and has needed NG tube feeding for her nutritional replacement. Her biopsy shows a HER2-positive cancer, which was PD-L1 CPS5, mismatch repair proficient. For her first-line therapy, she was recommended Capox, trastuzumab, and pembrolizumab based on her biomarkers. So she initially had a good response. At 6 months, then she commenced maintenance trastuzumab and pembrolizumab. However, at 9 months, she had increased dysphagia, and a CT showed increase in her disease volume with new onset of liver metastasis. So, Eric, for this patient who has developed progression after chemotherapy, trastuzumab, and pembrolizumab, what would you do next in terms of your treatment steps? Would you biopsy the primary? Would you biopsy the liver? Would you do no biopsy and move to second-line treatment? What are your considerations here?
Well, in an optimal world, and if the patient consents, then I would discuss with the patient to take a new biopsy. The tumor is progressing on first-line treatment on trastuzumab-containing first-line combination. We know that at the moment of progression, some patients lose their HER2 expression. Patient has still the primary tumor in place. An upper GI endoscopy is not such a difficult examination. So I would propose to the patient to do a new biopsy and to look at the HER2 status of the tumor.
I completely agree with you. So we know from retrospective and prospective data sets that up to 60% of patients can lose HER2 positivity. And I agree with you. If it's safe and feasible, a biopsy is preferred. And we do prefer an upper GI endoscopy if possible. The liver can be biopsied, but it is associated with more complications. So even though the liver is the site of progressive disease, I would prefer to do an upper endoscopy for this patient. And so, do we retest all the biomarkers or just HER2, Eric?
In gastric cancer, I would just retest HER2. PDL changes also over treatment, but there are no PD or PDL antibodies approved in second-line treatment of gastric cancer. The claudin antibodies are not approved in second line, and MSI highs or MSS status is not expected to change. So yes, HER2 is what we would do.
And I think so, in this situation, if we had a HER2 positive cancer, what would your recommended treatment be?
Well, today we would recommend treatment with trastuzumab deruxtecan if the tumor is HER2 positive. We have the data of the earlier studies in Asia, and also the Western study, the Destiny Gastric 02. In Asia was the Destiny Gastric 01 study. So if the tumor is HER2 positive, yes, that would be my preferred treatment.
So we've discussed that the answer should be clear if the biopsy shows a positivity for HER2. But if the repeat biopsy after trastuzumab is negative, which can happen in up to 50 or 60 even % of cases, what would your recommended treatment be then?
Yeah, that's a difficult question and a good question. I would then first challenge my pathologist and discuss with the pathologist whether there was enough material, how sure they are about the fact that there is that the tumor is HER2 negative, if enough biopsies were examined, and if the pathologists were quite sure about the technical aspects, then I would consider this as a HER2 negative tumor and rather go for a treatment with paclitaxel and ramucirumab in this situation.
I agree. I think if there is no evidence of HER2 positivity on the biopsy, we have good evidence for ramucirumab and paclitaxel rather than a HER2-directed therapy. It is, however, important to note that many of the patients in Destiny Gastric 01 did not have a repeat biopsy before they were treated with trastuzumab deruxtecan, and there is the issue of heterogeneity. However, on balance, I would also agree with you that in this situation, with a clear negative biopsy that has been done with adequate material, that non-HER2-directed therapy might be preferred. And perhaps TDXD or trastuzumab deruxtecan could be considered in third line or another chemotherapy option.
Yeah, correct.
It's important to also consider previous treatment and other treatments. So, for example, does the fact that the patient had pembrolizumab before second line make a difference to your reasoning?
No, for me that doesn't make any difference. The initial Destiny 01 and 02 study were done before the era of wide use of checkpoint inhibitors. But for me that doesn't make any difference. This pembrolizumab treatment was in first line. We're now discussing second line, and I don't think there is any evidence that influences.
I agree. There's no reason to suspect that there would be a negative interaction between pembrolizumab and further treatments after that round of chemotherapy and immunotherapy. What if the patient had previously received irinotecan? So we know that the payload in trastuzumab deruxtecan is a topoisomerase inhibitor. Do we know if a patient previously treated with irinotecan, for example, in second line, might benefit from trastuzumab deruxtecan in third line?
We don't know that, formally speaking. This was not within the trials. This was not looked at, but the mechanism of action is different. It's indeed trastuzumab deruxtecan with the payload, the topo-1 inhibitor, but with the ADC, the antibody drug conjugate, the mechanism of action is different. And I was still, despite the fact that we don't have any data, we don't have negative nor positive data, but I would still recommend them to treat a patient with trastuzumab deruxtecan.
Certainly, I think there were a small number of patients in Destiny Gastric 01 who might have previously been treated with irinotecan or similar drugs, and the outcomes broadly were similar, but this is a very small number of patients. And I agree with you, when it comes to antibody drug conjugates, we've really got the direct delivery of the chemotherapy payload to the tumor in a very targeted manner, which might overcome resistance to previously used drugs. So I think that's a very reasonable approach. So I think we've explored very much so the, thank you very much, Eric, for that discussion around our second line patient. And we can move in to think about where we are with trials in the second line setting for HER2 positive gastric cancer. So first of all, I'd like us to consider the ASPEN-06 study. This is a novel approach looking in the HER2 space. So evorpacept or ALX148 is not in fact a HER2-directed therapy, but almost like an immune checkpoint inhibitor in that it inhibits CD47, which is a signal molecule on macrophages, on the innate immune system. And so what this is telling the immune system is don't eat me, or eat me appropriately. We have an early study which was presented at GI this year, although GI ASCO this year, which is randomized, looking at evorpacept in conjunction with HER2-directed therapy. And what we saw was that adding this drug did improve response rates and did, although it also looked at an improvement in the tail of the curve. Although there was no significant improvement in the median progression-free survival, I think that you can clearly see those curves separating there, suggesting that adding this different immune checkpoint inhibitor to HER2-directed therapy could be an avenue to explore in future. What we are looking forward to this year are the results of a global phase 3 trial, which is Destiny Gastric 04. Eric has previously mentioned the Destiny Gastric 01 study, which evaluated trastuzumab deruxtecan in Asian patients with previously treated gastric and junctional cancer. That was a third-line plus study. And the Destiny Gastric 02 study, which looked at second-line treatment of trastuzumab deruxtecan in a non-randomized trial in a non-Asian population. Destiny Gastric 04 is a global phase 3 randomized trial which evaluated trastuzumab deruxtecan versus ramucirumab and paclitaxel in patients who had progressive disease on trastuzumab. So this is a phase 3 trial. It's quite large. I think we're looking forward to the results this year. And what's nice to see is that it's global. It's comparing trastuzumab deruxtecan against a well-established standard of care. Patients who entered this study were required to have a biopsy that showed retained HER2 positivity. So this will give us a very clear readout for a population who should be sensitive to trastuzumab deruxtecan. So I think we can look forward to the results of this study later this year, perhaps at ASCO 2025. So I would like to thank Eric for your discussion today around second-line treatment options for HER2-positive gastric and junctional cancer. Thank you to our listeners for your attention. Follow on to answer the questions and complete the evaluation.
This program was presented by Medscape Education Global.